So my name is Charles Morin, and I'm a psychologist by training. I've been at Laval University in Quebec City for the last, I have to think about it, 93, the last 30 years, and doing mostly insomnia work, clinical work on insomnia. And I started my career in the United States at the Medical College of Virginia. So I was there from 1986 to 1993, just before I moved back to Quebec City. That's where I come from originally. Well, actually, I knew nothing about sleep when I went to Virginia. I was hoping to get some training. Prior to that, I got my PhD in clinical psychology in Florida. I did my dissertation on insomnia in the elderly, so I had no trouble recruiting people. But in retrospect, I realized that I knew nothing about sleep, even if I did a clinical study on treating insomnia. So I wanted to learn about sleep, so I moved to Virginia for a postdoc fellowship. But a psychiatrist who brought me there left the department 1 month after I arrived there. So that was quite a challenge, but fortunately I had a good chair. He sent me to Stanford for a week-long course with Sharon Keenan and everyone else, the big names, Bill Dement, Christian Guillemino, Tom Roth, Chip Reynolds, Mary Cascadon, and all those big names. So this was a fantastic opportunity for me to get a feel for what was sleep all about. And after that, I continued my learning experience. I stayed on the faculty at the Medical College of Virginia for 7 years, doing both clinical sleep medicine, but also insomnia research studies. So it was a very nice blend and a good way to start my career, learning more than just about insomnia, but about all of the different sleep disorders. So that was a great head start for me in Virginia. Catesby was at Norfolk, so I got the pleasure to meet Catesby. We had this small Chesapeake Bay sleep meeting annually, moving from Washington to Norfolk, Richmond, North Carolina, UVA. So it was a great network that we developed there. So my area of expertise is really insomnia, but more specifically insomnia treatment. When I entered this field, I knew that there were people doing pharmacological research on insomnia, but I wanted to do something else as a psychologist, and particularly developing alternatives to treating insomnia with medication. So that's when I got interested in what was back then behavioral therapy for insomnia, and eventually it became cognitive behavioral therapy. So I have to say that I spent almost my entire career doing clinical research studies, testing different treatment protocols, CBT alone versus CBT versus medication, combined sequentially. I also had an interest in helping people come off sleep medications because many of the patients we see in clinical practice, they come to see us and they've already been on so many different medications, and some of them at least want to get off the medication. So I did some clinical studies also testing different tapering protocol to see how we could assist those people with the discontinuation process, which can be quite a challenge. So for me, I mean, conducting a randomized clinical trial, but something that is very applied with direct implications for clinical practice is really what has driven me throughout my career. Yeah, if we go back maybe 25, 30 years ago, we only heard about non-pharmacological therapies for insomnia, but that's a no name, so it meant anything that didn't involve medication. And then came the term sleep hygiene education. But even today, this is quite a popular terminology to describe non-pharmacological therapy. And many people think that when they do sleep hygiene education, they're doing CBT. But clearly, these are two different things. And sleep hygiene, as we know, is really providing basic education about the negative impact of stimulants and alcohol on sleep. But we also know from the literature that is clearly not enough as a single therapy for insomnia. So, if I may continue on this line, I mean, initially when I entered this field, I was quite influenced by people like Peter Horry, Dick Budzin, and Art Spielman. These, I must say, were kind of my three intellectual mentors, even if I've never worked directly with them. I've got to know them and presented at meetings with them, and I learned a great deal from their work. My challenge was trying to improve on and build on what they had developed and make it more credible to the field, because 25 years ago there was a lot of skepticism about what we can do to treat insomnia aside from using medication. So my first papers were clinical trials, randomized clinical trials, and probably one of the paper I'm most proud of was a comparative trial of CBT against temazepam, combined alone versus a placebo, a paper that was published in JAMA. It received a great deal of attention, and I think that from that point on, I felt legitimate with the type of study that I was running, and many of my colleagues were running in parallel. So that's how I guess, developed this interest for this field. Yeah, when we look at this emerging field of behavioral sleep medicine, it's kind of, in my view, that's still a field that deserves to take expansion, to expand. But the economics of sleep medicine is such that for psychologists, it's not easy to live on just providing psychotherapy. We know that the reimbursement issues is a big problem, even more so outside the United States. So I think there's quite a challenge there, but we need to continue developing ways to treat insomnia with behavioral sleep medicine providers. And now what's becoming increasingly popular is this field of digital therapy, digital CBTI. And I think it's a great tool to reach out to those people who do not have access to any form of treatment for insomnia. But sometimes I feel that people are getting a bit too enthusiastic, as if this would be the answer. Because we know CBTI works, not for everyone, but it's been shown effective, but it doesn't work for all patients. So we need to continue improving our treatment methodology for this problem. And digital CBTI is one way to give greater access, but I don't think that it will ever replace in-person therapy. When people have mild insomnia, that might be a good way to assist them. But we know that motivation to implement behavioral recommendation is often a problem. So if a person has to do it on his own or her own, that might be a difficult task. So I think that complementing in-person therapy with digital CBT is one thing, but asking people to drive this program alone may be kind of a risky business. Well, I think that there are many digital therapeutics, digital CBTI program on the market, but very few of them are supported by the evidence. Shut-eye is one of those, Sleepio is one of those, and there are several others. But compared to what's available on the web, I mean, we have to be careful because there are still many unsubstantiated claims. So I think that, of course, I've been involved with Shut-eye and Lee Ritterben and his team at UVA for many years. But if you look at the number of clinical trials behind this application, it's amazing. Same for Sleepio. So I think that these two probably stand out from the pack. But probably that the first experience with commercializing shut-eye with some rest was not such a great experience. So there are lessons to be learned from that. But I'm not a marketing person, so I don't know exactly what needs to be done differently. Yeah, well, the Society of Behavioral Sleep Medicine, I was involved with, I guess, among the first people involved in developing these societies with several of my colleagues. I think that we need this kind of society, but I think we need to be careful also to keep a good balance between professional issues and research issues. From my point of view, sometimes it's too focused on professional issues. They're legitimate, but my interest, my time is more into research. So maybe that I'm a little bit more disconnected, but I'm a member of the Society of Behavioral Sleep Medicine and will remain a member. And I think that we need people to develop that. Well, certainly that ASM and the Sleep Research Society were my home, are still my home in many regards. I attended my first sleep meeting, I think, in the mid-'80s in Washington, D.C. And from that day on, I knew that would be the place I would want to present my results. And this is how I have built my network over the years, that with psychology meetings. But I think that I have found more of a home within the sleep community, given the type of research I'm doing. I've been involved with ASM in writing and chairing the first task force on non-pharmacological therapies for insomnia. I think that we published the first paper, don't remember what year it was, late 80s, but I was chairing the task force and had people like Peter Horry, Dick Bootzin, Art Spillman, Jack Edinger, who were part of that task force. So that was an honor for me to be driving this group of people. I've also been quite involved with another society, the World Sleep Society. I've been president of the World Sleep Society. I'm the program chair for the scientific meeting. I've been program chair for the last two meetings, including the Rio meeting, which was had a couple of weeks ago, which was a big success. I mean, we draw 3,600 people in Rio. So I have really enjoyed my involvement with this international group of sleep medicine clinicians and researchers. Well, I think that an organization like ASM has tremendously helped this field grow over the last several decades. And we see this growth not only by the number of sleep centers that are available, but just by the recognition that sleep and sleep disorders is getting from the medical community. So I think this is critical for our field. And as a Canadian living in Canada now, I think that we're lagging way behind in terms of lobbying efforts with the governments to recognize this as a specialty. Not only that, but also to recognize sleep disorders as real problems that need treatment. Particularly, maybe not so much when it comes to sleep apnea, but certainly a problem like insomnia. I mean, we still need to do a great deal of representation with government officials to recognize this as a genuine clinical problem. But I think we're getting there now with all the evidence we're gathering about the long-term impact of insomnia, particularly when it's not treated in terms of increasing risk for depression, hypertension, and so forth. I think that even when we give lectures now to primary care practitioners, they're listening a little bit more. And I think that we used to trivialize this problem too much. Now I think that there are more people listening and more people interested also in sleep. I mean, it's in the forefront of the media all the time. So I think we have a big role to play in making this literature accessible to government officials, but also to the general public, because they're the one who can oftentimes influence government decisions. Well, I don't know if that's relevant, but the difference between Canada and the US, I mean, I practice in Virginia as a PhD clinical psychologist. I could read, study. I had my ACP credentials. I could read, study. I could bill for studies. And clearly I can do that in Canada. So from that point of view, that's a big, big difference. I don't know today. I mean, I'm talking now about 25, 30 years ago. I don't know how it is, but I mean, there are big economic differences. Even if in Canada we say we have a universal healthcare system, it doesn't mean that you have access to treatment when you need it, access to diagnosis and to treatment. So oftentimes you will need to pay if you don't want to be on a wait list for 12 months. And there are differences also between provinces. I'm in Quebec. It's very different than the situation in Ontario, for instance, in Toronto. There are many more sleep centers in Ontario compared to what we have in the province of Quebec, and it's strictly a business explanation in terms of reimbursement and all of that. I mean, in the province of Quebec, we can count the sleep centers on one hand, maybe two hands, but very, very few. Whereas in Ontario and other provinces, there are more. But again, it's nothing to compare with the US. We haven't seen this kind of blooming as we have in the US. Well, I have always found that in the US, the lobbying was very powerful. And I remember going to the Capitol with one of my patients when I was in Virginia. She testified to the National Commission of Sleep Disorders Research. Talk about some lobbying there, but we had the right person to do that in Bill Dement and Mary Cascadon and several other people. But I mean, I wish we had this kind of opportunity, but maybe we need to work harder, and maybe that's for people who are seniors in their career, maybe like me, to spend a bit more time trying to influence decision makers. Well, I mean, I'm a clinical psychologist by training, but in my heart, I'm a researcher, a clinical researcher. So I guess that I wear both hats, the scientist practitioner type of paradigm. And I think there's room for both, for people who want to be clinicians, for people who want to be researchers. At some point, you have to decide where you want to spend most of your time. And then on top of that, we are educators as well. But I think that when you do research, it's a very, very rewarding career. I mean, doing research is not easy, but when it's time to communicate your findings, it's fantastic. I mean, it's extremely reinforcing. And clearly, if I take the example of CBTI, today it's the first-line treatment. But this kind of recognition didn't happen overnight. I mean, it took decades of randomized clinical trials to reach that level of recognition. So in retrospect now, I feel that I, with some of my colleagues, have greatly contributed to that. Now we need to take it to the next level of not just being recognized, but being adopted and used in day-to-day clinical practice. We're not there yet. But for young trainees who want to get in the sleep medicine field, I think it's still wide open, and we just need to be creative. And there are all sorts of positions, clinicians, researchers, teachers that you can create. Well, that's probably the next step to get this level of adoption and implementation in clinical practice. That's where I think the lobbying efforts will need to take place. We know that we have the tools to treat insomnia, but it's not used. Currently, I mean, I think that's true worldwide, that there's an increasing rate of mental health problems. Sleep and sleep problems such as insomnia is part of this increased rate of mental health problems. So I think we have a good opportunity now, maybe to be creative and trying to get our foot in the door, so to speak. And digital CBTI may be one way to make it more accessible, but I think that we probably need to take a step back and do a little bit more of the health economics research to demonstrate that what we have to offer is not just clinically effective, but it's cost effective in terms of reducing absenteeism from work and in terms of reducing risk for several health problems. Some very fond memories. I think mostly going back to oh no, okay. I was going to mention my fond memories about coming back to Stanford, but
well, that's the next question. So if you want to do that one first, we can do that.
Okay. Well, I mean, today I presented a couple of lectures here at Stanford, and one was the Bill Dementz lecture, part of the Bill Dementz lecture series. So for me, it was a great honor to be invited to give this lecture for two reasons. First, because Dr. Dementz wrote the foreword of my 1993 book. So that was quite an honor for me when he accepted to do that. I was just very early in my career, so it was very, very impressive for me. And the other fun memory I had coming back here at Stanford was that when I started my career in sleep, I knew nothing about sleep, and my chairman from Virginia sent me here to take a week-long course on sleep medicine that was chaired by Sharon Keenan with all those big names, Bill Dement, Mary Cascadon, Tom Roth, Christian Gilmino, and many more. So, I mean, these are really good memories for me, and that's 35 years ago. So that I'm still cherishing today. I'm trying to remember, I think some fun memories of my first AASM meetings were when I first met people like Peter Horry, Dick Bootsin, and Art Spillman. I mean, when you're a graduate student and you read those people, you always imagine that they're going to be old. And when you get to meet them, you're surprised that they're not so old after that. But it was very impressive for me to meet. These were, like I said earlier, my intellectual mentors. So getting a chance first to meet them, and then over the subsequent meetings to share the same platform, to present results or do clinical workshop. It was really nice. I remember in particular one workshop that Peter Horry chaired, and he had asked me, we had a real patient with us, he had asked me to demonstrate how we do cognitive therapy. And I mean, explaining how you do sleep restriction and stimulus control is fairly pragmatic. It's very directive. When you do cognitive therapy, you challenge people about the way they're thinking about their insomnia and how it impacts their lives. So there's some more nuances there. But this was quite a challenge, but I really enjoyed doing that. Well, I mean, I can testify that AASM/SRS have always been a great place to network, to develop. There's always been opportunities for young investigators. This is so important. And even today, there's funding for new investigators. There are different ways of supporting new people to the field. This is so important to keep the younger generation come up and be interested in this field. So we have to continue doing that.